Hey guys, so today I am going to talk about my experience in Tanzania, specifically involving midwifery and how their system differed from ours. Now, when I was a Rotary exchange student, we used to have this motto that it's not better, it's not worse, it's just different. And I really want to go into this video with that mindset. Essentially, this will be detailing my personal experience at the specific hospital that I was in Arusha, Tanzania. So I'm not saying that this is the same way all over Africa or even all over Tanzania. So this is just the differences that I noticed there. So one of the most prominent ones was just how they manage labour and birth. So similar to maybe Australia and England is that the women come in early labour to get assessed. If they're 4 centimetres they stay, and if they're not then they go home and come back when they have progressed further. So if the women were 4 centimetres they go into a labouring room, and this room was about 7 or 8 beds and all these women labouring together. Then next door there were birthing rooms, and a woman would go here when they were 10 centimetres dilated to deliver. Because sometimes when I explained it to people they imagined dirt huts, but it was actually like maybe a hospital in the 60s or 70s here is how I would imagine it. The beds all lined up, they're just normal beds, they don't lift or anything like the ones we have, but they are useful nonetheless. So generally the women would not make it to the delivery suite and they would end up delivering in front of each other. And while this might seem quite shocking, I find it to be quite a nice communal experience where women weren't alone. In terms of documentation, what they had there was every woman did have an antenatal card similar to what we have here, and then when they came in the midwives would write in English little paragraphs of notes. It was similar to here, but it was a lot less than we would probably be expected to write. In terms of fetal monitoring, while they did have Dopplers, the midwives actually preferred to use the pinards or fetoscopes because that's how they were trained, and I think they found it a lot easier to use. So in terms of the regularity of observations, I personally found it to be quite random how they would monitor. That being said, I did not speak the language, so I did not understand the rationale for certain actions and certain procedures, but I found it to be quite random and a little bit disorganized, but they did certainly get monitored, and some women did go for cesarean, say for fetal distress. Another thing I found quite different to here was that the women did not have any pain relief whatsoever. So they were just expected to labour without pain relief, and they all coped incredibly. These women are so strong. However, if they were to make a lot of noise, sometimes the midwives were quite physical with them, would kind of hit them around a little bit and yell at them to be quiet. So this was a little bit confronting, but I feel like when I was there I just tried some acupressure on the women and really tried to use my normal birth skills. So massage, positional changes, just encouragement really. So when the women came in, they would have kangas, which are just like pieces of fabric. So they would come in with about 5 or 6 kangas. One would go in the bed that they would birth on, one they would wrap around them, and then 2 would be for the baby, and 1 might be for the cleanup after birth. The cleanup and their concepts of like sterile field was also very interesting. They were very strict with some things and not so strict with others. Again, because I didn't speak the language, I couldn't quite get the rationale. But some things like you would always have to double glove no matter what, but then you'd be putting your glove. So they had a system of like, you put the dirty stuff in chlorine, then soapy water, then fresh water. Yep, so then after they went through that process, they would get wrapped up in a cloth and then sterilized with the cloth over it, which was interesting, and then they would just come out ready for use. A lot of their instruments had rust on them. So for example, episiotomies were generally done with a razor blade, which does sound awful, but it's a lot better than rusty blunt scissors, because the razor blades were once used and they came in like a sterile packet and they were very sharp. So even though it's kind of a more confronting way to do an episiotomy, it was definitely the better option in that case. Probably one of the most confronting things to me was how they broke waters. So to break waters, what they would do is like the oxytocin ampules, when they use them they would break them off and keep them, and then some of the doctors would place them up the woman's vagina to break the waters. Other things they would do, the instrument that you use to clamp the cord down, they would kind of bend it in half and then stick it up the vagina to break the waters, and sometimes they would just try and manually do it with their fingers or use a needle. Obviously, so in Australia we use the Amni hooks, quite like a crochet hook, but they just didn't exist, and even when we went to the medical supply store to try and buy some, they don't have anything like that. Another thing that was used quite regularly, which was quite intense, was that they would use a lot of fundal pressure to get the baby out, or as the woman's pushing. So essentially the accoucheur would stand near the vagina to receive the baby, and someone would be pushing down on the woman's uterus to physically push the baby out. So the reasons why this isn't normally done is it can cause uterine rupture. I did not see any uterine rupture while I was there, but I did see a lot of fundal pressure used. So they use it in lieu of forceps or a vacuum. They do have kind of a bit more archaic versions of forceps and vacuums, but they're not normally used. Fundal pressure is the go-to method. So I thought it was quite interesting because it did work for them. It did get babies that were distressed out quicker. But the ramifications of that to me are kind of unknown, especially long-term damage, what it does to the uterus, I'm not really sure. But it was an interesting practice to witness. Another interesting thing was breastfeeding and the postnatal period at whole. So I find here, especially working as assistant midwife on the postnatal ward, that postnatal care is one of the most kind of intense areas and where women require the most help. However, in Africa, as soon as the baby's born, there isn't skin to skin. It's just taken to a heater while the mother is either stitched up or just cleaned up. And then it's given to the mum. They sit on a bench after they've had a baby and they can breastfeed there. There's no assistance or demonstration given, but a lot of the women just put the baby straight on and successfully fed, so it was very interesting to see. So the postnatal care was a lot more relaxed. When they did go to the ward, a child and family health nurse would go there as well and do the vaccinations for baby and give education. So another thing I found super interesting is because there was no pain relief, there was a lot of normal birth, a lot of normal active labors, and because of this, I believe I saw not one PPH. So I saw between 50 and 100 deliveries. I really didn't keep count. Some days there were quite a lot and some days there weren't so much. But I never saw one woman have a postpartum hemorrhage, which was very interesting. So they do interventions like breaking the waters and augmenting labors as well as inducing, but yeah, but I didn't see any PPHs there. I don't know if it was just like a lucky time of year or if it really did have to do with not really having a choice but to honor the normal process of birth. Another thing that was really interesting, as I mentioned previously, is they do induce and augment labours with oxytocin, but I felt there was really no rhyme or reason to how much they gave. So sometimes they would put 20 units in a bag, sometimes put 10 units in a bag, but the bags weren't labelled and they were switching out bags between women. So it did get a bit confusing at times, but I feel like they knew what was going on. I think it was just confusing for someone who's really used to labels and procedures and double checking all the time. Also with cannulation, so I got to do cannulation there, which was very beneficial, but the cannulas they had there, they were sterile, but they were quite blunt. So when you put them in, the tip would go in, but the actual plastic cannula bit is quite difficult to get it in. So when you saw the midwives put it in, of course they were used to it and they just used quite a lot of force and it went straight in, but a couple of times when I tried, I really struggled. So another thing you might wonder is about cesareans. So at the hospital I was at, they did do cesareans, and it was a very interesting procedure to watch. So I only chose to watch one because I was more there to practice and enhance my normal birth skills, but I did want to see what a cesarean was like there. So I will just speak for the one that I saw. Their sterility was really, really good. I was super impressed. The one that I watched, only the doctor and an intern performed the cesarean, so it was them two working together. There wasn't a lot of staff. I think there was one theatre nurse who was sorting out the instruments, but it was very low-key. There weren't a lot of people in the room. A weird thing was sometimes you would see flies in the theatre, which was very different, but they just shoo it away and keep going on. When the spinal analgesia was put in, they don't actually give local, so they just put the spinal needle straight in and the woman that I saw didn't even move, didn't even flinch or make a sound. In that culture, keeping face and being quite stoic is very prominent, and it really puts me to shame when I complain about stubbing my toe or something like that. They are very strong women. So whilst most of the care was midwifery led, obstetricians did have quite a lot of involvement. Generally they were the only ones to perform the vaginal examinations, and they would do the more difficult deliveries. In terms of staff, there were 3 midwives to that labour room, so it could have been 3 to 3, which is obviously ideal, but sometimes it was like 3 to 7, 3 to 8, and that's where I think I was able to help a lot more. So some of the other differences were little cultural differences. For example, no men were allowed in the labour room, of course, because there were many women labouring in there. Women also have to buy all their own supplies for their labour and birth, so the needles to give the oxytocin, cotton to clean up, even suturing if they require that. They need to bring it all in themselves. One of the biggest differences as well is that there were never paediatricians present at the birth, no matter if it was a premature baby or known fetal distress. The midwives had to handle all resuscitations, and how they perform resuscitations as well was very different. Again, as an outsider, it appeared that there was really no rhyme or kind of process to it. It was that you just kept trying a lot of different things, but of course I didn't speak the language, so I didn't exactly know if they had a certain method. But obviously here, when the baby comes out, you know, you monitor the heart rate and you make, and the breathing, and you make actions based off that. There, if the baby came out non-responsive, they had a thing called a penguin, which was like those blue sucker things that can suck fluid out of babies' noses. I forget what they're called, but they would, if a baby came out flat, they'd like call for the penguin, and it was like a thing, and it was shaped like a penguin, and they would suction the baby's nose, stick it down the baby's throat and suction that out. If that didn't work, they'd take the baby to the resus, and then they would just more use stimulation. So sometimes they'd have the baby's feet, slap the baby's feet, move the baby's head from side to side, hold the baby upside down and rub its back. And they did have a bag of masks, but they would kind of do a few and then not, and then do a few more and then not really. So one instance I remember is that, that a baby came out flat, and they worked on it for quite a while, and then it eventually came around, and the doctor said, oh, how long did it take for that baby to come around and start breathing? And they were like, oh, 10 minutes. And he went, wow, that's great, 10 minutes is great. Whereas in Australia, 10 minutes would be a little bit more of concern, because you'd be thinking about things like brain damage, and you'd probably expect, if a baby wasn't breathing by then, for it to be intubated or be on CPAP. So it was just interesting comparing the outcomes. Another really confronting area was the NICUs. The care was generally one nurse for about 20 babies. In terms of oxygen, so they had 2 oxygen kind of tubes that they could put in babies. But if there were 5 babies requiring it, they would have to switch them between the babies. Each baby would have to have a turn of the oxygen, essentially. One of the most confronting things I saw there was a 22-weeker that had been alive for about 3 weeks since I'd been there. So it didn't always have the oxygen in. Again, sometimes it was breathing spontaneously, but it was breathing, it had a heartbeat. And it was moving, and it was such an interesting thing to see, because obviously in Australia it was completely tied up with machines, but here it was almost a miracle to see it. They also had babies there with jaundice, so they did have the capacity to perform phototherapy. I remember when I delivered a 28-weeker, then it was delivered, and I thought straight away it would be rushed to the NICU, but the midwife kind of wrapped it around, walked around, finished the woman's paperwork. There's really no rush and no sense of urgency. But generally it seemed as though the babies were having pretty good outcomes. So I was originally hesitant to make this video because, as you can see, there's so much to talk about. It's quite difficult to follow a sort of template or any sort of organization. So if this came across a bit all over the place and rambly, I apologize. If you have any other questions, leave them below. I will answer them, but if there's quite a lot, I will make another video about my experiences in Africa. If there's anything you want me to expand on as well, just let me know. As always, thank you for watching. This was another video made because of a suggestion, so if you have any other suggestions, let me know and I will do my best to make them. If you're not following my Midwifery and a Mother's Instagram, the link is below. I post more frequently now that I'm finished uni and have a life again. I start my new graduate job in March, so I will be posting a lot about what it's like to be a midwife for the first time and be a new graduate midwife when I start that, so look out for that video. I'm also going to do one on how vaginal exams kind of clicked for me and how I was able to figure them out, so look out for that as well. Thanks again for watching, and I will see you in my next video.